Today's webinar will deal with fixed implant restorations, primarily multiple implants splinted together as fixed bridge work, and then some also on fabricating immediate provisionals and single implant crowns. The next webinar will deal with fixed cases a la all-on-4 hybrid appliances, prosthetic procedures and considerations for the fabrication of the temporary all-on-4 appliance, as well as the final, including conventional and accelerated methods. And then the final webinar will illustrate the use of prosthetic procedures to fabricate overdentures. Both the all-on-4 and the overdenture webinars will also feature the use of conventional acrylics versus the use of fully milled acrylics, and I will share with you some of the advantages of both. So without further ado, let's move into today's program. This case will illustrate extraction of tooth number 8 and the use of the patient's tooth and existing crown to fabricate the immediate provisional restoration. So with the tooth extracted and with the implant in place, first thing I'm going to do is just make a short measurement with my Bowley gauge to determine how much of the root I want to remove from the extracted tooth. Then I'm going to, in this case, utilize a titanium temporary abutment from Nobel Biocare. I'll be cutting that down, shaping it as you see on the upper right-hand part of the screen, prepping it, if you will, so that I can then use that as an abutment for the immediate temporary crown. On the chair side, I'm simply cutting off the root at about approximately the measurement that I've made on the upper left-hand part of the screen. I will then hollow out the rest of that root and pick up the titanium temporary abutment with a provisional material. In this case, I'll be using Luxatemp. So I'm basically retrofitting the old tooth and crown hollowed out with Luxatemp, picking up the temporary titanium abutment, and I'll be making a screw-retained temporary restoration. Here we have it in place on the lower left-hand part of the screen, looking from the lingual. I have hollowed out or created an access opening so that I can screw the, I can retain the temporary crown with the screw, and then I'll seal that opening with Teflon tape and some sort of temporary material. One important part of an immediate fixed restoration is to make sure that the patient does not make any contact in centric relation or any excursive movements, particularly as the patient moves anterior-posteriorly. So in many of these cases, as you'll see on the lower right-hand part of the screen, the incisal ledge position of the immediate provisional is slightly shorter than the original crown in order to make sure that we don't make any contact on that in that vulnerable period of the implant integration. Approximately 3 months later, we torque tested the implant to confirm that it's completely osseointegrated. There's no movement or discomfort upon putting in 35 Newton centimeters of force on the implant screw. And after an implant level impression, in this case, we're going to make a screw retained final crown, an Emax screw retained zirconia crown cemented to a zirconia abutment. And Microdental has left me an access opening there for me to be able to bond the crown to the existing or to the shown zirconia abutment. In some cases, you can have the laboratory go ahead and bond that together, and you simply insert the entire apparatus, crown and abutment as one unit and screw it into place. You also see the codes for the crown and the abutments on the screen. So here we have the final crown, which has been cemented or bonded to zirconia abutment for screw retention and retrieval. If for any reason we want to get back down to the top of the implant, or we have any issue with the abutment, crown, or implant, we can simply access through the lingual access opening, unscrew the crown, and retrieve that without having to cut it off. You can see the crown bonded to the zirconia abutment in the x-ray. And I'll illustrate that bonding procedure shortly. In this case, we had a little bit of color differentiation between 7, 8, and 9. So we blended the color. The back team at Micro did a nice job of blending that for me between the shades of 7 and 9. Final restoration, this is about 2 years out from delivery. The patient has been probably out about 5 years at this point. Patient's very happy, satisfied, and we fortunately never had to retrieve the crown or abutment. This will illustrate the procedure for cementing the crown to the zirconia abutment. So we're simply going to hold the crown in one hand, the zirconia abutment in another. The assistant will be helping me with this procedure. I'm going to bond or cement this extraorally after treating the internal portion of the crown. I don't need to completely fill the crown. I don't want any more excess cement than necessary. But by holding the crown in place here, the assistant can then come in with a micro brush and clean off any excess material that we can see visually. If you do this intraorally, then you will want to unscrew the crown and take a look at the interface between the crown and the abutment to make sure that any excess cement has been removed. The problem with cementing crowns is illustrated here. This is a fairly excessive amount of cement. There's quite a bit of excess cement that was found underneath an implant cemented crown. Normally, I would not expect to see this much excess cement if we're careful in cementing, but it does illustrate the potential problem for trapped cement subgingivally, which could create a problem and even cause the loss of an implant. And so screw retention has become increasingly recommended these days, if and when possible. On our next case, I'd like to illustrate the use of an implant fixed bridge over multiple implants, of course, as well as an implant crown side by side. We're going to utilize the angled screw channel from Nobel Biocare because this will allow us to bolt a zirconia milled bridge and a single zirconia crown to a metal base without using any cement. The entire fixation for the bridge or crown is by the screw retention of the milled zirconia to its titanium base. Therefore, the crown and bridge is retrievable and repairable very easily if that ever became necessary. So what we're looking at here is an anterior fixed implant bridge, numbers 6 through 10, with a single implant crown screw retained on number 11. And I think it looks like a nice result here, but I also think it's important to realize where we started. You get a little better look at that on the model because we've also utilized some very nice custom pink porcelain to fill in the space between the cervical portion of the milled zirconia. So that is entirely zirconia, which is layered over by Emax porcelain. And you might think that's a pretty nice result as well. I hope you do. But especially when we look at the full face, a nice presentation, but let's remember how it all started. And this was the case the day we received the patient. after a severe traumatic accident. So as you can imagine, and we'll show some more slides shortly, this patient suffered quite a bit of trauma to the facial area. And that was strictly from falling off of a curb, hitting her face first, knocking out 5 anterior crowns and teeth attached to bridge work as well as natural roots. And we ultimately lost the number 11 tooth as well. So that was how we started on a Saturday afternoon when the patient presented after her accident. There's a radiograph of the fractured teeth, and as you can see, number 11 is still in place there. That will be lost ultimately due to a fractured root. There's a close-up, best we could get, a photo of the cracked roots, and again, number 11 will be extracted at a later date. This slide illustrates several weeks later, after the teeth, upon extraction of the teeth and a large grafting procedure that was done by our surgical dentist. There was so inadequate buccolingual morphology or width of the bone. The teeth were extracted, a major graft was done. We could not place implants at that time, so we had to make a removable appliance. So we put the patient into an Essex retainer that day. It's not exactly the most attractive restoration, but it will suffice in the interim period of time until we can get implants into place. So the patient wears that for a short period of time, and then once we get some consolidation of the graft, we're ready to place implants. We also lost a bridge on the upper right-hand side, so there's one implant to be placed in the number 5 site, already an implant in 6. Then the implant bridge will consist of, that's 5 that's already in present. The implant bridge will consist of 6 through 10, and then a single implant crown in 11. As you'll see here with the implants in place, the patient already had been treated with a mandibular all-on-4 appliance. So there will be 3 basic appointments once we get to the point where the implants are integrated. And once we have torque tested the implants to confirm that they're completely osseointegrated and ready for restoration. We will go in at that time to make an open tray impression and send that to the laboratory. We'll get master cast fabricated, and then the laboratory will start helping me design the case virtually on the computer. They'll send me screenshots for me to suggest any alterations and then ultimately approve. Before we actually fabricate the bridge, however, we will want to have an acrylic verification jig sent back to our office for us to try in. Since we will be splinting a fully milled zirconia portion of the bridge together, we have to make sure that our master cast is accurate, and we do that with an acrylic verification jig, followed by more lab screenshots and virtual designs, and then eventually delivering the case on the 3rd appointment. We take a look at the first section here, an open tray impression. I'll be sending photos to the lab as well for shade verification as well as other design items. If we're going to splint implants together for screw retention, it's imperative that we use an open tray concept. So here we have open tray impression copings on the implants ready to send to the laboratory for a similar case. The laboratory will then send me back an acrylic verification jig. In this particular case, we are splinting all 3 implants together. However, we will wind up with an implant, a single implant on number 11. So the implant bridge will be 5 units from 6 through 10. Here we have the implants in place and a radiograph of all the implants in place, illustrating that the titanium temporary cylinders do completely seat to the implant platforms. So we have a passively fitted acrylic verification jig. And this lets us feel confident that we can construct our fully milled zirconia base on the master cast. Example of screenshots that were sent to me by Microdental. We will tweak those some as we work through the case, and then we will also fabricate the single implant crown on number 11. Another look at the screenshots. And of course, as you know, if you've done these, you can also have links sent to you so that you can rotate those images. But screen still shots typically do very well for us. So another look at our 3 appointments. An initial open tray impression. Second appointment is an acrylic verification jig sent to us to verify the accuracy of the model, and the completion of the case and delivery. Quite a bit of back and forth between myself and the laboratory technicians at the MAC team at Microdental as we designed the cervical portions of the fully milled zirconia and then layering over that with Emax porcelain and then tinting that to create some pink porcelain material. By being able to do this, we avoid that super long looking tooth form if we did it all in white porcelain. From a lingual view, we see 2 implants supporting the 5-unit bridge. The implants in the numbers 6 and 9 sites we're cantilevering into the 10 site. And then we have the single implant crown on number 11. We also noticed that we have a single screw retained crown on the number 4 position, but we made it more of a molar size to get as much occlusal function as possible. We utilize the angle screw channel format from Nobel, which allows us to connect this titanium base to the crown or the bridge without any cement. So the case is delivered to us with this titanium base inserted into the zirconia. This requires a special driver from Nobel, the angle screw driver, that allows us to tighten in and utilize the angled screw. So the head of that screw fits only this Omni driver from Nobel. When you put that into the angled screw, you can see the angulation option that is available to us. On a model, on the upper portion, you see the titanium base inserted into the implant replica for the conical connection. And then over on the right-hand portion, you see the replica itself. So again, the fixed bridge and or crown basically is in 2 segments. You have individual titanium bases, and when the superstructure is connected to the base with the screw, the entire restoration becomes fixed, but there is no bonding or cement in that area. Therefore, if we did need to retrieve, if we ever had any chipping or fracturing of porcelain, it's an easy procedure to retrieve the entire crown or bridge, send that back to the lab. There's no need to put that into a burnout oven to destroy the cement and worry about some possible damage to the restoration. I like this format a lot because in the out years, what we learned we have to plan for is possible damage to the implant restorations. Typically, those implants are going to last very, very well, either for the patients the rest of their lives or for a very long time. The weak link is typically going to be the prosthetics. And we need to think about how we can repair the prosthetics, if at all possible, while still preserving the original prosthetic appliance. So here we have single implant on approximately number 3 site, the implant bridge from 6 through 10, an implant crown, all screw retained here. These are Nobel active implants, as you can see by the aggressive thread formation, and then an existing implant that was already in place, and another existing implant that was in place on numbers 11 and 12. So this patient obviously has quite a bit of history with implants, and you can see a multi-generational evolution of placement of implants in her mouth. As I mentioned previously, she had had an all-on-4 appliance constructed approximately a year and a half or so before the accident to the maxilla. A good x-ray illustrating the interface between the zirconia to its titanium base, and of course with a single implant crown for the titanium base retention, the base will be an engaging titanium base. For the bridge work, it will be non-engaging since we're splinting multiple implants together. Then if we look at the restoration with the lips retracted, and then in a patient's smile, we see a good lip drape. Very little, if any, of the pink porcelain will be viewed unless the patient really goes into an animated smile. Lingual views of the completed restorations. These screw access holes are first covered with Teflon tape, packed down into the screw heads, and then sealed over that with either composite or some sort of temporary filling material, in this case, composite. And another look of the completed bridge work, 6 through 10, implant crown on 11. The a little tinting is also achieved by using some GC Gradia custom color material and staining that the MAC team at Micro was able to incorporate into the fired porcelain. A final look, again a smile and face, and one more look back retrospectively at where we started. Okay, this is a look at the titanium base. The single base, that would be for an engaging restoration, another engaging titanium base that is bolted to the crown by the angled screw. And one of the reasons that we really like this retrievable option is, if you've been around and practicing for a long period of time, you've probably seen this situation develop, as I have. This is a very, very long, large, cement retained bridge, almost a full arch cement retained bridge done 20 years ago by us. And finally, the porcelain fractured here on tooth number 7. Taking that bridge off is a real problem. You'd have to cut it off. It would just be a total nightmare. So in order to repair this, we have to prep into that porcelain, make a porcelain veneer, if you will. In this case, we did it with Emax, and then bond that to the existing fixed bridge, which we were able to do. But if we have screw retained restorations, these types of repairs become much more facilitated, much easier and less costly to the patient. Our next case illustrates one more screw retained restoration using the angled screw channel from another traumatic workplace injury. The patient was a nurse, and she was actually hit by a patient in the emergency room, fracturing her premaxilla, developed a septic infection. She had multiple soft tissue grafts and bone grafts done. She actually had some implants that were placed and then lost, and then more grafts were done. So lots of trauma to this premaxilla area. We also ultimately had to do an endodontic procedure on number 10 and the crown on it. So here we have 3 implants that were placed, and this was the way we received the patient in our office after some previous treatments. Nobel Bowel Care conical connection implants, 3.5 millimeter diameter implant in approximately the number 7 site, and then 4.3s in the 8 and 9 sites. Not a lot of attached tissue here, but enough to utilize. The implant number 7 is just about at the gingival crest here. So it's not an ideal situation, but we were frankly very fortunate to receive the patient with any implants in place at all. So at this point, it's our challenge to restore. Now, she was already restored with some crowns previously, I'll show you, and then I'll illustrate the solution that we came up with. Here she is again preoperatively before any restorations. She was having to wear a temporary removable partial denture appliance with no contact at all on the grafted areas as well as on the healing abutments. Crowns were fabricated, and it was a very good effort by our dentist to do that, but due to the severe degree of loss of hard and soft tissues, the aesthetics were not acceptable to the patient, and also there was some spacing in the interproximal areas that made it difficult for the patient to speak correctly. So looking at that procedure, I elected to make basically a screw retain hybrid appliance. And since we're going to split all of those implants together, we're not going to do single implant crowns. Once again, we're going to make an acrylic verification jig. In this case, we're going to make a temporary restoration first to sort of road test the concept for the final appliance. So this illustrates the provisional restorations fabricated for us by the MAC team at Microdental. This is entirely composite material, including GC America's Gradia Nature Krill material to give it that pink replacement of gingival tissue look. So we fabricated this appliance. It does have a flange, and we'll talk about that shortly, but that flange has to be there in order to give the teeth a more normal look. We will have screw retention here, and we're going to splint all of the implants together. So we're basically going to try to simulate what we think we would like to wind up with in the final appliance, but we're going to put this in and leave this in intraorally for at least a month to determine how well the patient can clean. Generally speaking, a lot of gingival shade tabs are not very effective in matching to gingival colors. This is one from that MAC team at Micro was able to send to me, and we were able to use that as a reference for the GC Gradia material. So here's our provisional appliance in place. We just have provisional crowns on 6 and 10. But we kept the patient in this appliance for about a month, brought her back, removed the appliance, and take a look at how much debris is accumulated underneath there. Because one of the big considerations would be with that facial flange in place, is the patient going to collect so much debris and bacteria that we would jeopardize the existing implants? This slide was taken immediately upon removal of the temporary appliance, and we see a small amount of debris, but very little. And so we could extrapolate from that yes, we probably will remove the final appliance periodically, and whether that would be at 3, 6, or 12-month intervals remains to be seen. And skipping forward to the final appliance that we have here, this is fully milled zirconia, layered facially with Emax porcelain and then tinted to simulate or duplicate, if possible, the same color that we wound up with in our provisional restoration. And once again, we're using the angled screw channel from Nobel so that this entire appliance will be connected to the titanium bases with the bolted screws. And the patient very, very pleased, very happy after insertion of the appliance. We followed her for about 2 years now. We've removed the appliance on about an annual basis here. And again, we found very little debris, but enough that necessitates removal of the appliance. The patient realizes that that will have to be done periodically. Okay, let's take a look at how much time we have left here. We're at about 34 minutes and counting. So I'm actually going to zip to another portion of the program. So I want to illustrate this case that was published. I published this case earlier in the Academy of General Dentistry's publication, General Dentistry. I received this patient after orthodontics had been in place for quite a number of years. And the orthodontist actually moved this tooth, this bicuspid, anteriorly in order to try to drag some bone forward and create some bone and negate the need for grafting prior to implants. However, there's still a large buccal defect here. And so we are going to have to extract that nominal tooth and have a major graft, basically a buccal onlay graft done. Now, once again, I'm making the patient an Essex retainer while the grafting procedure is done and the graft consolidates, and then ultimately we can place implants. So in this case, we're going to utilize the Nobel Biocare clinician software and surgical guide technique. So after, and this was done several years ago, the process is somewhat more streamlined today than it might be. And of course, also today, the surgical template could be either milled or printed. In this case, it was milled after the CT scan was merged with a scan of the edentulous cast. We've got our sites here positioned for placement of 3 implants. And they are already predetermined for these diameters of implants, and these will be received, the Nobel replace implants, the tri-lobe implants. So at the time of surgery, the surgical template is in position. The osteotomies are drilled through the guided surgery template. You can see the reflection of the tissue here and the implants in place, numbers 5, 6, and 7. In a case like this, where I'm going to immediately fabricate immediate provisional restoration splinted together, with that degree of surgery done, it's a fairly messy field for me to have to go in and pick up all of my abutments intraorally. Therefore, I'm going to do an implant level impression immediately upon placement of the implants after suturing. I'll pour a master cast in quick setting stone that sets in about 15 minutes or less, and then go right in and start prepping abutments and retrofitting my laboratory fabricated provisionals. I'm trying in the fabricated provisionals after I've picked up my temporary abutments. There you see the temporaries in place. This lab fabricated provisional 5, 6, 7 has been retrofitted to some plastic temporary abutments from Nobel. Those will go in. Here we are 1 week after placement of the implants as well as the temporaries, keeping those out of occlusion, a very strict adherence to that concept so that we don't damage those vulnerable implants, particularly in the first 3 weeks after placement. And again, about a week after placement, then approximately 3 months after the implants were placed, torque test was accomplished, confirming osseointegration. In this case, we're going to use single zirconia abutments. We will not be splinting the finals together, of course. And Microdental has now fabricated some Emax crowns with lingual access openings for us. And we bonded those together extraorally, seated all 3 of the final implant crowns, and sealed those with Teflon tape over the screw heads, and then composite. Final x-ray, again, implants all in place with zirconia abutments and Emax crowns. 6 months post-restoration, 3 years post-restoration. No other orthodontics was done. The patient declined any other cosmetic work to be done. And 3 years post-restoration. And this was at about 5 years post-restoration. Okay, I want to illustrate one other thing. We've talked a little bit about guided temporary surgical templates, and those are all fine. Here's just an example of a guided surgical template that I utilize to place implants in these 3 sites on the maxilla. This is the guided template. And when I look down through the holes at my master cast, I can see that they were very accurately placed through the guided template. But I also want to illustrate something that I do fairly often, which is a model-based surgical template. And I can make this template for particularly single posterior crowns in about 15 minutes or less. So with a denture tooth in place, I can fabricate a 2 millimeter shim or even a 1 millimeter shim over the denture tooth, and then either keep that in place or fill that with some clear material, drill my hole for the guiding of the initial osteotomy. Typically a 2 millimeter hole or a 3 millimeter hole is drilled. Here you see one made in office through denture teeth for 2 bicuspid size, or it can be filled with triad clear material. And there's your triad clear material. And I use this a lot, particularly if I don't feel like it's necessary to go to a guided surgical technique. Certainly that can be accomplished far more economically. And I'll finish very quickly here. I want to illustrate 2 separate cases. This case we received after the patient was about 2 years out with these implant crowns in numbers 7 and 10. The patient was very dissatisfied with the aesthetic look, and we have quite a bit of kind of a weeping gingival problem here around both implants. And of course, as it would be, the patient has a very high smile line, a gummy smile. So everything shows when the patient smiles. I'm just going to illustrate this because I want to illustrate the need for pre-surgical planning to try to avoid that kind of problem. These were the original crowns that we removed, and then ultimately we fabricated new crowns. Some major grafting procedure was done, but still you never are able to typically make this look really, really good. So I want to, in order to compare that, I want to illustrate this other case that we did. We received the patient after orthodontic treatment was done. We specified to the orthodontist we want a minimum of 6 millimeters root to root between these teeth, and we want those roots of the central incisors and the cuspids to be as vertical as possible. So we'd like for the gingival, we'd like for the platform of the implant to be about 3 millimeters from the final gingival crest in order to have a good emergence profile of the crown. Today, we certainly could and might very well in the aesthetic zone utilize a guided surgical technique. But I wanted to illustrate this by being a model-based surgical template. This is a processed acrylic template made by the laboratory. I have drilled the osteotomy sites slightly lingual to the cingulum areas to guide the surgical placement. A surgical colleague has placed the implants and then sent the patient directly to me. Fortunately, the surgical dentist has utilized a papilla-sparing technique. Then I'm making immediate provisional crowns on these zirconia abutments. So I didn't have teeth to use for that. So from a diagnostic wax up, I have a shim, filling that with Luxatemp, and then that will be cemented to those temporary zirconia abutments. Today, in most cases, we would make screw-retained immediate provisionals. These are the temporary abutments, the temporary crowns in place approximately 1 week after the surgical placement. And then as that tissue matures, we are able to see a resolution of this inflammation here, but actually we want just a little bit of edema there to make sure that we have a good full thickness of gingival architecture. 4 months later, 3 months later, we're able to do our implant level impression, and we're able to wind up with our final implant crowns with the gingival zenith approximately 1 millimeter below the gingival zenith of the central incisors. So that looks pretty good. Here we are 8 months after placement of the implant crowns, and once again, we have very good fill of the interproximal areas. No black holes are in evidence. The gingival tissue tone is pink and healthy. It looks very, very good. And the zenith, again, is slightly below the zenith of the central incisor and the cuspid. But that result is accomplished by a lot of coordination between you, the restorative dentist, and or your surgical colleague, or if you're doing all the surgery, making sure that you get a good surgical template and that you do not allow the implants to be placed in a position that would severely compromise the prosthetic results. There we are, the final x-rays, and before and after. So if I'm correct here, we're at about 46 minutes. And I think this is probably a good place to stop. So at this point, I'm happy to entertain any questions that the audience might have. I'll just go to another x-ray here. Another slide here. Okay. So I'll ask Ten to assist me here and see if we have any questions that need to be answered.
Thank you, Dr. Strong. Thank you for the informative presentation. We will now transition into the Q&A portion of our webinar. I will look at the Q&A and I will read the questions to you, Dr. Strong. If anyone have questions, please feel free to answer or ask. And I apologize in advance if we're unable to answer everyone's questions since our time is limited. But Dr. Strong, you can send him a direct email and he will answer any of your questions. And again, everyone, I want to thank everyone for attending Microdental's CE webinar. We look forward to your participation in our upcoming webinars. You can email me directly for more details on this. And again, thank you for Dr. Strong for your partnership on this speaking engagement. As mentioned, if attendees have any follow-up questions, you can always email Dr. Strong or me, and we can gladly help assist.
Thank you.
Okay, so Dr. Strong, the first question is, can you go through the steps of making temporary for anterior cases?
Yes, let me go back to a slide and, well, I'm not going to be able to do that. So let me just verbalize that. So if we're going to make an immediate provisional crown for a single implant in the aesthetic zone, once the implant is placed, I will select either a titanium temporary abutment. Nobel Nobel makes titanium temporary abutments and plastic temporary abutments, PEEK material, PEK. And you might select either one. It doesn't really matter. The PEEK material, the plastic material does not have a show-through issue like titanium can. So you might select that. Prep that as need be for incisal length and lingual clearance. Screw that into the implant, and then you would like to have a shim, generally made off of a diagnostic wax up, that you can insert in the mouth over the prepped temporary abutment. I'll fill that with Luxatemp provisional material, let it set, remove the shim, and then I'll simply drill through the lingual portion of the Luxatemp to access the retaining screw. By doing that, I can remove the entire provisional restoration. So I will have picked up the temporary Luxatemp to the temporary abutment. Generally speaking, the Luxatemp will not cover all the way down to the margin of the temporary abutment, which is fine. You don't want to trap a lot of Luxatemp subgingivally. And then chair side, extraorally, I will add Luxaflow to the remaining portion of the abutment that's needs to be covered. Add that, light cure it, and trim it and polish it, then put it back in the mouth and adjust the occlusion for clearance lingually and incisally. Then once I'm satisfied with that end result, we will insert the temporary screw retained provisional, pack Teflon tape over the screw head, and then fill the lingual access opening, usually with a temporary material like Fermit, F-E-R-M-I-T, which is light cured material. It's easier to drill back through that and access the screw head. So that's just a verbal description of making the immediate temporary restoration.
Okay, I hope that answered your question. I hope I'm spelling your name correctly, Dr. Imran Rizivi. We will continue to still answer questions. We will have a hard stop at 12 p.m. PST time, but we are free right now to answer any questions if you have.
I mentioned that if you have questions regarding that, you're welcome to email me at info@strongdentallectures.com.
And I will also put that in our chat as well, his email. If you have any questions, feel free to ask. Everyone, I just want to remind everyone and reiterate that if you need your CE credits, once you exit Zoom webinar, to please, a new browser will appear. It will be the CE evaluation form. Please make sure you fill out in order to receive your CE credit. As a reminder as well, your minutes will be recorded, so please make sure you stayed for the whole 1 hour duration. All right, I see more questions. Dr. Strong, one, are there any particular crowns you would avoid in restoring posterior teeth with implants?
I'm not sure if I quite understand the question. Are there any crowns that I would avoid using on posterior implants? I'm going to assume that's the question. And if I may, I will just list, so to speak, the types of crowns that we typically utilize for posterior single implant restorations. Our go-to these days is fully milled zirconia. If we're in a non-cosmetic area, then I really like the strength that I gain from the fully milled zirconia. That's designed by me and the laboratory technician. I typically am getting screenshots back from the micro lab technician as to the design of the final milled zirconia crown. That would be my first preference. If we have a real cosmetically concerned area that perhaps, say, a first or second bicuspid in the maxilla, I certainly will consider layering the facial and slightly over the buccal cusp with something like Emax porcelain. But I would like the load-bearing area to be all zirconia. Today, I would still prefer that over our traditional porcelain fused to metal restorations, because you certainly can, as you know, see some chipping or fracturing of the fired porcelain to the metal understructure. So far, I'm not interested in restoring posterior single implant crowns with any kind of acrylic material. I know that our printed materials are coming on, and that certainly could be an option. As far as in-office milled restorations, that's not something that we do in our office, but I've certainly seen in-office milled restorations that have been done with implants that have been successful. But just to repeat, my preference would be in a non-cosmetic area would be fully milled zirconia implant crown, screw retained, which can be stained or tinted to basically whatever shade you desire.
All right. I hope that answered your question. That was by anonymous, so I do not have the name. Next question, what material you use for the 3-unit bridge implant retain?
The case that I think you're referring to was the trauma case in the maxillary anterior, replacing numbers 7, 8, and 9. So the MAC team at Micro designed with me the fully milled zirconia infrastructure from Nobel. And then that was cut back, designed with a cutback for application of Emax porcelain to the facial area, and then further stained or tinted with the pink porcelain materials. I just have to mention Gloria at the MAC team did such a superb job in working with us and blending and matching that pink porcelain to the color of the composite that we were able to achieve. Fully milled zirconia with a cutback on the facial, layered with Emax porcelain on the facial.
Okay, we have 2 more questions that we can answer before we do a hard stop. So your next one is, what type of occlusion do you recommend on your implant? Do your crowns have ideal morphology?
Well, it depends on the existing occlusion, of course, if you're doing single implants or even a small zone. Generally speaking, I would like to have what Dr. Mish used to call an implant protected occlusion, and others, which would allow for a very light contact in centric relation. Preferably, I would like to have little to no contact in excursive movements. Certainly want to minimize that in the off-axis loading of the implant crown or bridge. Oh, if it's a single implant crown, for example, we will ask for a very, very light occlusion on the model. I'll check that in the mouth. And then I want to make sure that the patient can hold shim stock, which is 10 thousandths of an inch uh, metal, very thin material. Place that in, have the patient close. We want that shim stock to hold on the adjacent teeth in centric relation. We'd like for that to pull through on the implant crown or to only be held in very light occlusion. So there may be some time spent in the final adjustment of occlusion there. I will also deal with occlusal concepts in the all-on-4 and the overdenture cases, which of course are fully edentulous cases, and that's a completely different type of occlusal scheme.
Okay, great question. We can take one more. A question from Dr. Kenneth Hamlet. Are you scanning any abutments for final restorations?
Yes, thank you, Dr. Hamlet. I didn't have time to illustrate that. I do have that in the slides, but we didn't get to it. And I actually call that the future of implant impressions ? So I think that increasingly we will all be scanning our abutments. You'll have scan bodies, as you well know, that are seated into the implants, and then you'll scan that with your intraoral scanner. And I think that works very well. I have certainly done that on many cases. I still utilize standard impressions, though, in many cases as well. But I think increasingly, particularly for those of you who are using in-office milling, you'll be doing that as well.
Great. Thank you for that question, Dr. Hamlet. Okay, so this will conclude the end of our webinar.